All right, can you guys see the screen? Yes, no?
Yep.
Okay, so today I'm going to do the first virtual journal club on cardiorenal syndrome. The purpose of this is for the house staff to be more familiar with cardiorenal syndrome, so I'm going to go over the definition, the pathophysiology behind cardiorenal syndrome, the diagnostic strategies, including biomarkers, the imaging modalities, treatment strategies, and what the future holds. This is not a single paper, but it's a consensus statement, scientific statement by the American Heart Association and Dr. Rangaswami, who is the Associate Program Director at Thomas Jefferson. And so I'll start it. I mean, cardiorenal syndrome.
How you cause?
I'm sorry. Okay. So we'll just jump on in. So I have nothing to disclose. So the way to begin is to define what it is. And so cardiorenal syndrome encompasses a spectrum of disorders involving both the heart and kidneys, in which acute or chronic dysfunction in one organ may induce acute or chronic dysfunction in the other organ. And it's really divided into two major groups, cardiorenal and renal cardiac syndromes. And they describe this based on what they call the prima movens. And prima movens just translates into which one is the first moving one. It has been divided up into 5 different types. Type 1 is acute cardiorenal syndrome. An example of this is heart failure resulting in acute kidney injury. Clinical example, acute cardiac syndrome resulting in cardiogenic shock and AKI. Acute heart failure resulting in AKI. Type 2 cardiorenal syndrome is chronic cardiorenal syndrome, where chronic heart failure results in chronic kidney disease. Example of this would be chronic heart failure. Type 3 changes around the prima movens to renal cardiac syndrome acutely, AKI resulting in an acute heart failure. An example of this is heart failure in this setting of AKI from volume overload, inflammatory surge, and metabolic disturbances in uremia. Type 4 cardiorenal syndrome, called chronic renal cardiac syndrome, and previously in the literature was called uremic cardiomyopathy, CKD resulting in chronic heart failure, left ventricular hypertrophy, and heart failure from CKD-associated cardiomyopathy. And type 5 is secondary cardiorenal syndrome. It's usually due to a systemic process resulting in heart failure and kidney failure. Examples of this is amyloidosis, sepsis, and cirrhosis. 2 months ago, we had a inpatient patient with leukemia had type 5 CRS. So this next slide really goes into the pathophysiology of cardiorenal syndrome, and we're going to give an example of the cardiocentric prima movens. So it starts with the inability of the failing heart to generate a forward flow, and thus it results in pre-renal hypoperfusion. So the mechanism is inadequate renal flow, activates the RAS axis, the sympathetic nervous system response, which increases arginine vasopressin secretion, which leads to fluid retention, and increased preload, which leads to worsening pump failure. I'd like to remind everyone the kidneys receive disproportionately a large percentage of the cardiac output, approximately 25%, and it's a very low resistance circuit. Due to its low resistance, the renal vasculature and parenchyma and the very low oxygen tension in the outer medulla also explain the unique sensitivity to the kidneys to hypotension-induced injury. In this diagram here, it shows the multiple pathways, and we're going to go into each of them individually. But as an overall example, if the heart suffers an acute insult like ischemia, cardiomyopathy, or an arrhythmia, this leads to a lot of downstream effects. One of them has to do with our CNS, with vagal and glossopharyngeal afferents from high-pressure baroreceptors, leading to increased ABP, increased sympathetic nerve tone, and peripheral vasoconstriction, leading to eventually acute kidney injury. A decreased cardiac output will lead to increased ANP and BNP, which blocks natriuresis. Decreased cardiac output will also lead to decreased perfusion, which increases venous pressure. Decreased cardiac output will also lead to increased humoral signaling, increased cytokine secretion, which eventually will lead to downstream effects within the kidney tubules of renal hypoperfusion, tubular cell toxicity, decreased GFR, diuretic resistance, which we will definitely go into later in this topic, and organ edema. All of this also has effects back on the heart, causing angiotensin II release, which increases peripheral vasoconstriction. On the next slide, we're going to talk about diagnostic strategies. These diagnostic strategies are really based upon biomarkers, and each of the biomarkers have their own specificity and sensitivities. So I'm going to give you an example of each one. Some of these are not available in the US, but are coming soon, so I'll mention which ones those are. So in order, we'll start with cystatin C. Cystatin C is a cysteine protease. It's ubiquitous in all nucleated cells, which is this. I'm contrasting this to creatinine, which is mostly in the skeletal muscle. So the cysteine protease is in all nucleated cells. It's produced at a constant rate. It's freely filtered. It's completely reabsorbed, and it's not secreted at all in the renal tubules. Urine microscopy it can also help distinguish intrinsic cause of AKI from functional changes in serum creatinine in the setting especially of acute heart failure. The next one down on this is NGAL. NGAL is neutrophil gelatinase associated lipocalin. And this is a protein found in neutrophil granules. It's secreted by renal tubular epithelium, myocardial cells, and other specific organ sites. And it's been studied well in cardiorenal syndrome. It has both a diagnostic and prognostic value, especially in acute heart failure, and as well as in chronic heart failure. It's the most upregulated protein produced by the kidneys in the setting of AKI. It's not currently available in the US. It's mostly in the European countries, but it should be available by 2021 in their estimates. The next one in this list is TIMP2. It's tissue inhibitor of metalloproteinase 2, as well as IGF-BP7, insulin-like growth factor binding protein 7. These are both tubular biomarkers involved in the G1 cell cycle arrest during the early phase of cell injury. The cardiac biomarkers, some of these that we are very familiar with, such as BNP and proBNP. The other ones that are less familiar with are ST2, also known as suppressor of tumorigenicity 2. This is a decoy protein produced by endothelial cells lining the left ventricle and aortic outflow tract in response to biomechanical strain. The next one in this is galectin-3. Galectin-3 is a beta-galactoside binding lectin family. It's synthesized by cardiac macrophages and is known to interact with specific extracellular matrix proteins, including laminin, senexin, integrins. And the other ones that we're familiar with that we use all the time in the hospital are troponins. Obviously, the troponins have diagnostic and prognostic markers, especially in acute myocardial infarction, and prognostic values in acute decompensated heart failure, and is also increased during declining GFR associated with increased mortality. The imaging modalities that are currently available are echocardiography. Echocardiography is able to measure central venous pressure, systolic PA pressure, wedge pressure, left atrial pressure, and cardiac output. Just of special detail also, some institutions will have speckle echocardiography that can do strain analysis. This allows more of a detailed analysis of myocardial systolic function in the setting of a normal left ventricular ejection fraction. It may have additive value over echocardiography and assessment of ejection fraction, including type 4 uremic cardiomyopathy. Renal ultrasonography and intrarenal venous flow. This can demonstrate renal venous congestion, chronicity of disease with renal size, echogenicity, cortical thickness, and abnormal cortical-medullary ratios. There's also cardiac magnetic resonance imaging. This can help us assess ventricular dimensions, functions, and fibrosis. So one of the questions that comes up is how can we accurately measure volume status? And so there are emerging modalities not available everywhere and require special technicians to be available. But the ones that have been studied well are listed here on the slide, and I'll start with the bioimpedance vector analysis, and the image of the bioimpedance vector analysis is on this slide as well. So this involves total body water measured by placing a pair of electrodes on the dorsum of the wrist and ipsilateral ankle, and then you apply a 50 kilohertz current to the body. This would be displayed graphically so that the relative hydration is depicted in accordance to vector length. So shorter vectors would be associated with volume overload, and longer vectors would be volume depletion. So if we look at the image here on the right, you can see that relative hydration status is really determined by the net vector of resistance applied to the current and reactance. So if you look on the slide here, they have a measure of blood pressure in accordance with blood volume, and these are relative changes. The most important part is actually on the small 3 graphs on the bottom, which this does is it's creating a vector of, is the patient dehydrated, does the patient have a lot of fluid, or are they somewhere in between? These results of the bioimpedance vector analysis are compared with measurements made from healthy reference populations, and they're plotted on different ellipses, the 50th, 75th, and 90th percentiles. The phase angles corresponds to the portion of the electric current that is stored and subsequently released in different phase, and depends on multiple factors like cell integrity, cell membrane permeability, and total body water, which varies in individuals as well. So that's why there's reference ranges in the 50th, 75th, and 90th percentiles. The other things that we can do is we can measure intra-abdominal pressure monitoring. It's just a simple bedside, non-invasive measurement. It can be obtained by a urinary bladder catheter connected to a transducer. And in advanced heart failure, these patients have inefficient natriuresis with progression volume overload. So it may lead to a state of systemic congestion with increased intra-abdominal pressure, especially if the capacitance function of the splanchnic vasculature is insufficient. Other things we can do are relative blood volume. This is radio-labeled albumin tracer injections. It's a really good tool for intravascular blood volume. There's also implantable hemodynamic monitoring devices. They can assess transthoracic impedance as a measure of pulmonary fluid status. The last one on here is actually not recommended, but I want you to know because it has been well studied. It would be invasive hemodynamic monitoring, and this was well demonstrated in the ESCAPE trial. It's not recommended in acute heart failure. So the ESCAPE trial, it did not show a reduction in either mortality or rehospitalizations with such a strategy in patients with right-sided heart catheterization. And post-hoc analysis actually showed that a PA catheter-guided strategy was associated with less average increase in creatinine and did not decrease the incidence of defining worsening renal impairment during hospitalization or affect renal function after discharge relative to the clinical assessment alone. Nevertheless, the PA catheterization can still be warranted in patients with cardiorenal syndrome who are difficult to treat, and you're aiming to identify and treat subclinical congestion while trying to avoid intravascular underfilling and modulating hemodynamics to improve dual organ function. So the importance here is, and this is still going to be established over the next coming year, is treatment. So treatment largely revolves around decongestive therapies. And these decongestive therapies, the ones that are well studied, are in diuretics. So the loop diuretics that are available are furosemide, bumetanide, torsemide, ethacrenic acid. And the mechanism of these, just for review, is they inhibit the sodium potassium chloride cotransporter in the thick ascending limb of the loop of Henle, and this leads to natriuresis and volume loss. The great thing about the diuretics is their short duration of action. They can last 2 to 3 hours and up to 6 hours. And from all of the studies so far, high-dose intermittent furosemide is safe and effective. One of the novel things, and one of the things that are still being researched in the literature, and now with the addition of the Cardiorenal Society of America, is diuretic resistance. And so This really has to do with the attenuation of the maximal diuretic effect that ultimately limits sodium and chloride excretion and is a well-characterized phenomenon of diuretic use. It's associated with renal impairment, increased risk of hospitalization after heart failure, and mortality. So just as review, especially in diuretics, oral furosemide has about 50% bioavailability, whereas intravenous and, believe it or not, sub-Q infusions of furosemide ensure about 100% bioavailability. Bumetanide and torsemide have a higher bioavailability than furosemide, and loop diuretics are 95% protein bound. So patients with hypoalbuminemia have increases of volume of distribution and reduces the availability of loop diuretics for facilitated diffusion. In the image here, we are going to go over the diuretic resistance as well as something called the braking phenomenon. So in the image, there's several extrarenal and renal factors that impede the delivery of a diuretic to the site of action in the nephron. After initial efficacy, actually diuretics become less effective, and this is because of the braking phenomenon and distal tubular remodeling. So this braking phenomenon refers to a diminished diuretic efficacy with each successive dose. The effect is observed within hours, but the mechanism is still unclear. Sodium loss is thought to play a role in the upregulation of proximal and distal sodium transporters, and sodium repletion can actually attenuate this compensation. So in turn, this becomes a braking phenomenon. Potential strategies to overcome diuretic resistance is increased dose, increased frequency, and the combination of diuretic therapy. Other modes of treatment, which are less studied and still, gaining approval with FDA, ultrafiltration is still well known, and this requires passing blood through hollow fibers made of semi-permeable material while applying a negative pressure to the space surrounding the fibers, causing isotonic fluid to be removed from the intravascular space. So the composition of the ultrafiltrate contrasts with the much lower sodium content in the urine produced by the loop diuretics and allows decongestion without the use of loop diuretics. And potential benefits include less potassium wasting, less renin and aldosterone release, and increased sodium loss. However, they've been seen from these studies that there is increased weight loss, but there's also increases in serum creatinine and a higher rate of adverse events from this method. The other ones I'm going to mention here are not as well studied, and tolvaptan and nirmatrelvir are FDA approved in special circumstances, and dopamine and dobutamine we'll review as well. So tolvaptan is a selective V2 receptor antagonist, and it causes aquaresis without loss of sodium. Nirmatrelvir is a recombinant BNP with both venous, arterial, and coronary vasodilatory properties. It reduces afterload and increases cardiac output without the inotropic effects. However, this neurohormonal modulation, both with tolvaptan and nirmatrelvir, in the setting of acute heart failure, has failed to improve heart clinical and renal endpoints in large randomized studies. So we really won't go into the details of tolvaptan or nirmatrelvir. Dopamine is a catecholamine with effects on beta and alpha adrenergic receptors, as well as the renal dopaminergic receptors, resulting in cardiac inotropy, systemic vasoconstriction, and improved renal blood flow. Early studies supported the renal protective effects of low-dose dopamine. However, subsequent studies demonstrated a lack of long-term clinical improvement in treatment of acute heart failure. Meta-analysis in terms of dobutamine have demonstrated improved urine output, but no significant difference in change in creatinine, rehospitalizations, or mortality with low-dose dobutamine. So I want to talk about RAS inhibition next. RAS inhibition, usually we talk about ACE inhibitors and ARBs. RAS inhibition is slowing CKD progression, is well established. The strength of evidence of ACE inhibitors in heart failure with pre-dialytic CKD is not established, given the lack of inclusion of these patients in randomized clinical trials for heart failure. Long-term efficacy of achieving complete suppression of RAS with an ACE inhibitor ARB is limited by the phenomenon of aldosterone escape, resulting in an increased level of serum aldosterone. So what is proven? What do we know? And I'm going to demonstrate this again in the quality of evidence in the next slide, especially in the cases of pre-dialytic CKD, is that ACE and ARBs slow CKD progression. They do have an initial increase in creatinine. There's hyperkalemia. There's lack of randomized clinical trials in this situation. And where there is a randomized clinical trial ongoing right now, it's called Stop ACE-I. That trial should be completed, I believe, in the next 6 months to 1 year. Other things that have been studied are the ARNIs, decreased mortality. There's more hypertension, less renal impairment, less hyperkalemia, slower rate of decrease in estimated GFR, and a modest increase in albuminuria. There's mineralocorticoid receptor antagonists, MRAs. These add to ACE and ARB, provides more suppression of RAS with potential long-term cardiorenal benefits, but again, there's the risk of hyperkalemia. And beta blockers have been proven in heart failure. There's a paucity of data in CKD, and meta-analysis of heart failure in CKD reveals that decrease all-cause mortality and cardiovascular mortality. So this was what I was talking about with the level of evidence with different therapies for heart failure and non-dialytic CKD. And as you can see in the bottom, they've divided up into CKD stages 1 and 2, CKD stage 3, and then 4 and 5. And these have shown the relative strengths of evidence for goal-directed medical therapies. As you can see here, we've reviewed the major ones with the strong things such as ACE inhibitors, ARBs, ARNIs, MRAs, beta blockers. And a lot of these have been studied more in the heart failure setting, but they have done post hoc analysis to combine them with the CKD stages. We'll talk about cardiac resynchronization therapy, ICD, in the next few slides. One of the interesting parts of this consensus statement, scientific statement, is that they started to address SGLT2 inhibitors and anti-diabetic therapies, not just because of their anti-diabetic properties, but also their role in management in acute heart failure, especially with the SGLT2 inhibitors, and now their role in cardiorenal syndrome. So metformin is well known. Metformin is still first-line therapies, but now with the addition of SGLT2 inhibitors, they have seen decreased cardiovascular death, non-fatal MI, non-fatal stroke, decreased incidence or worsening of nephropathy, reduction in CKD progression, delaying dialysis by 1 year, and decreased death from renal causes. GLP-1 receptor antagonists also have shown reduction in the rate of non-fatal stroke, non-significant decrease in non-fatal MI, and no significance in cardiovascular death. Again, this data is still from the 2019 information. Reduction also in new onset persistent macroalbuminuria, persistent doubling of serum creatinine level, end-stage kidney disease or death caused by kidney disease. The evidence is lacking currently in the DPP-4 inhibitors. One of the slides I wanted to definitely mention was obesity, despite it only being one small paragraph in the whole paper, is that cardiorenal metabolic syndrome is still being studied, but there's multifactorial again, and just like in any other vascular disease. So there's insulin resistance, which leads to impaired insulin metabolic signaling, correlation with proteinuria, there's correlation with impaired kidney function. Obviously, there's other risk factors such as hypertension, dyslipidemia, chronic inflammation, also reduced availability of nitric oxide, which contributes to the impaired diastolic mechanics. The reason this is important, again, is that we always keep thinking about heart failure and decreased forward flow to the kidney, but also the venous congestion, increased CVP, and renal venous congestion is a large portion of acute kidney injury and worsening renal function in cardiorenal syndrome. So these population-based strategies targeting obesity are really critical and to reduce this cardiorenal metabolic syndrome, and it's a major burden of morbidity, mortality, and healthcare costs worldwide. So talking about cardiac device therapy, implantable cardiac defibrillators in CKD have confounding data. Cardiac resynchronization therapy has proven to decrease all-cause mortality and quality of life. However, baseline CKD has negative impact on post-cardiac resynchronization therapy outcomes and a higher risk of all-cause mortality. Mechanical circulatory support devices, evidence is lacking. There is a single center reduction in AKI with percutaneous ventricular assist device using during high-risk PCI. So reduced survival has been consistently described as primary prevention ICDs in CKD, as well as higher complication rates, which include higher rate of infection, greater bleeding, central venous stenosis, tricuspid regurgitation. CKD may actually have a higher defibrillation threshold than the general population. ICD obviously is associated with a survival benefit, and in the post hoc analysis, it's with a survival benefit of GFR greater than 60. Another study, though, the ICDs and non-dialytic CKD, there was actually a lowered risk of death from estimated GFR 45 to 59. And then another study, there was no change in mortality. So there's definitely a lack of saying, in patients who have this heart failure that require ICDs, what is the mortality benefit at which GFR is still unsure. And it seems like these studies still have not been proven one way or another. For the cardiac synchronization therapy, just to review, it uses a biventricular pacemaker that electrically activates both the right ventricle and the left ventricle in a synchronized manner, which is supposed to improve ventricular contraction and reduce the degree of mitral regurgitation. So in terms of heart failure and kidney transplant, there is improvement in the left ventricular ejection fraction post-kidney transplant, but post-kidney transplant mortality rose with a lower baseline ejection fraction. There's a longer pre-kidney transplant dialysis duration only factor that independently predicted failure to improve LVEF. In terms of de novo heart failure and de novo ischemic heart disease, there's still limited data with kidney transplants. Heart failure management post-kidney transplant has limited data also with conflicting evidence, and baseline pulmonary hypertension is associated with worse post-kidney transplant outcomes. Palliative care and cardiorenal syndrome. Cardiorenal syndrome has high mortality, high healthcare resource use, and poor quality of life. The most common symptoms patients complain about are dyspnea, fatigue, chronic pain, and depression. Skeletal fractures and fall risk are important. Pain control, obviously with the CKD, you want to avoid NSAIDs and morphine, and you want to consider other pain regimens such as hydromorphone, oxycodone, fentanyl, methadone. Dyspnea is multifactorial. So where does the future hold for this cardiorenal syndrome? And it really is to define what are the composite outcomes and what are we really targeting to prevent. And so this slide is all about major adverse renal and cardiac events, also termed MARS. So major adverse renal cardiovascular events, this includes composite myocardial infarction, need for renal replacement therapy, stroke, heart failure, hospitalizations for cardiac reasons, hospitalizations for renal reasons, and death. Also major adverse kidney events, composite of persistently impaired renal function, new hemodialysis, and death. So this will really help us allow the clinical consequences of acute kidney injury and the effects of different interventions, and then we can define more accurately what we're trying to target. This is one of the greatest slides, and I do believe it hits home the summary of the whole article. So I want to say verbatim what the future holds and what we have learned so far, especially in terms of treatment management and defining the events that we're trying to prevent. So what we like to do is distinguish true acute kidney injury from functional causes of fluctuations in serum creatinine in the context of diuresis for acute decompensated heart failure. And this is critical in ensuring delivery of goal-directed medical therapies. We want to identify factors contributing to diuretic resistance, and that's a key step in decongestion for cardiorenal syndrome. We want to identify which biomarkers of cardiac and kidney injury represent a new dimension and diagnostic algorithm for evaluating heart failure with impaired kidney function and offer a prognostic value in acute and chronic cardiorenal syndrome. And another reason why I bring this up is because in acute kidney injury, creatinine may not rise for the first 48 hours, and especially in these intensive care patients in the future, a cystatin C and when available in the US, NGAL can be elevated within the first 24 hours, actually in the first 8 hours. We need more high quality data, but so far we do have great data for goal-directed medical therapy in chronic cardiorenal syndrome with moderate to severe declining kidney function. But we still need more randomized clinical trials. There needs to be a multidisciplinary approach for cardiac device therapies to reduce arrhythmia burden in heart failure and CKD. Palliative care is an underused strategy in the dual burden of heart failure and advanced CKD. And we need to have this cardionephrology multidisciplinary approach, the joint management of cardiorenal syndrome. This is my references. There's 290 of them, so it's all from the actual paper. And so I'll take questions.
I have a question. Sure.
Sure.
Yeah, I was able to follow some of it, not all of it. It was above my head, but I have a question. Linking it to the current COVID-19, those patients that have, cardiorenal dysfunction, what type is it? Is it type 5? Where would these viral COVID influenza like, a cardiac renal manifestations, where would it fit? What type?
So I think Dr. Juhar or Dr. Apanopoulos will have to chime in here, but from what I've read on this thing, the way they're trying to classify this phenotype is which one came first. So is it the cardiorenal prima movens, or is it the renal cardiac prima movens, or is the secondary to an underlying infection? And so it really depends, I believe, on the patient's baseline. Do they have a baseline of heart failure? Do they have a baseline of kidney failure? If the answer is no, and they're being admitted for another reason, such as sepsis, this COVID infection is causing them to be infected and they're, requiring ventilation management, then I would put them in type 5. But if they're coming in with chronic heart failure, chronic kidney disease, and decompensating heart failure, then I think it's multifactorial.
Yeah, no, I was talking, let's say for the patient that we had, let's say it's a healthy, relatively healthy gentleman with no significant or minimal comorbidities, who then develops COVID-19 and then goes into cardiorenal failure. Presumably there's some of the cytokine storms, what classification, because I think the management may be different in some of those patients. The traditional diuretics or vasopressin or norepinephrine, the management may be different. Dr. Benabli, you can probably comment more on this.
Yeah. So, Dr. Kobos, I have seen a couple of papers on this one with the COVID-19 causing viral cardiomyopathy, and then also COVID-19 patients having the kidney failure itself. So, COVID-19 causing sepsis itself, any kind of cytokine-mediated injury can cause ATN. And in this case of COVID, they have so much of surge of the cytokine-mediated damage. It is definitely, we are seeing a very high amount of the patients having the kidney failure as part of the sepsis with the cytokine surge. And when patients, not everybody is having the cardiomyopathy, like myocarditis because of the viral, but they are a lot of cases where they have seen patients do have cardiomyopathy, having high CPK, and they have some indication saying that patients do have myocarditis. So the idea is either this mostly fits in the cardiorenal syndrome type 5, given that the COVID is the main reason. Even they have a history of CKD or heart failure in the past, but sepsis is like making it worse. Yeah. But if you already have a pre-existing condition, we cannot say completely it's because of the cardiorenal type 5, but of course it is exacerbation is because of the sepsis. And how are we treating these patients is basically to control the volume first, because most of these patients are in the ICU with ARDS. And these patients, we are doing mostly CRRT as tolerated. If the patients are not tolerating hemodialysis, the idea is not just the volume removal itself, but the cytokine, the CPK levels, and it's overall trying to see what we can do along with the dialysis, because dialysis can little bit decrease the lactic acid, decrease the cytokine. There is a small amount of the dialysis component which helps with the sepsis. That was shown in CRRT trials where the CRRT helps in sepsis patients for any other reason, like why they're in the hospital rather than the hemodialysis. But it's not like a major, data that we have to support that. But as I said, like, early dialysis as much as possible, not like early, just for the indications of the dialysis itself, like, kidney failure itself. But I would definitely consider it as a cardiorenal syndrome type 5, given the sepsis and the COVID-19 affecting both the heart and the kidney at the same time. And Dr. Gilhart?
To add to this myocarditis business thing, there was one report from China that there was documented myocarditis from COVID, and the patient was treated and successfully treated, basically. And the physicians that treated him, he had very poor LV function, and then after treatment, the LV function recovered. From Italy, there was a report that they had 3 acute myocarditis during the outbreak of the COVID in Italy, but all 3 of them had biopsy, myocardial biopsy, and none of the biopsies were actually, it was the biopsy was confirmed the myocarditis, but none of those 3 patients actually were positive for COVID. So even though there is we think that COVID could cause myocarditis. Myocarditis is kind of a diagnosis of exclusion, and it has to be proven with the myocardial biopsy. So I did not see very many reports from either Europe or China with the acute myocarditis, but I agree with Dr. Agnopoli that this is like, if this patient come in with kidney failure, acute kidney injury, this is very likely type 5. And again, as everybody knows, we still don't know a lot of the stuff about COVID. That is, basically what the whole the spectrum of the disease is.
And one of the other comments, these different types, there can be, not in the COVID case, but overall there can be overlap between these different types. These different types were a consensus statement to target these endpoints, clinically relevant endpoints in study materials. But Dr. McCullough, who's the final author on this paper and is the founder of the Cardiorenal Society of America, also, said that there's clinically overlaps in multiple cases. So you don't have to be, in one of these certain types.
But one of the things that actually I want to bring house staff attention to is type 1 cardiorenal syndrome. The patient comes with acute decompensated heart failure. They are bio-overloaded, they have lower extremity edema, jugular venous pressure is elevated, chest X-ray show pulmonary vascular congestion, creatinine is 1.2, 1.3. And then they start giving these patients diuretic, and then the next day creatinine becomes 1.4, and it becomes 1.8, 1.9, 2, and 3. BUN goes all the way up to 100, and everybody freaks out, even though the patient has continue having lower extreme edema, have jugular venous distension, and the chest X-ray findings of pulmonary edema. So you have to be careful that it is rapid rise of the creatinine, BUN and creatinine are scary. But if the patient is not improving, holding back the diuretics or giving the patients IV fluid is not going to resolve the issue. So be very careful that as soon as when you have this patient with acute heart failure, especially with the very low EF. Recently, we did have one patient that had EF of like 10%, and her creatinine went from 1.2 to 3.6. BUN went up from like baseline of 40 or something, and all the way up to 100. And diuretics were held, and the patient was given IV fluid. That's actually another that will not really help in the patient's volume status. Sometimes when it gets to this point, we might have asked our nephrology colleague, because I have to be dialyzing patients for a day or two, for a couple of times to just get rid of the fluid and help them to keep in mind and not get that numbers to.
From my perspective, because obviously it's not my field, but it makes me wonder the times when there's sort of a difference of opinion, let's say between critical care and nephrology, or cardiology and nephrology, or cardiology and critical care, is that there may be some overlap between these, whether it's type 1, 2, 3, 4, or 5 of the CRS. And the management is slightly different from each one, but it emphasized the point that Tushar was making, is that we probably don't have, we need better biomarkers that can help us clarify, because the traditional biomarkers that we use, may not be ideal in a specific type of CRS.
Oh, that is true. I mean, I don't think we have, there's so much overlap of 1, 2, 3, and 4 that it's sometimes very difficult to delineate them. And it is true, I mean, we do have this agreement that comes from nephrologists, cardiologists, critical care physicians. But one way that I always go by is this: how much patient, what is the, how much patient. A lot of time I go by hitting edema. A lot of the patient in the ICU and the recovered patient, the impulse might be completely free of edema, but if you go to the sacral area, to the dependent area, how by edema, how much edema?
Well, that's why, because on some of them, like for type 5, you might want to avoid fluid overload, you might want to avoid diuretics, and some of them you do. That's why I'm wondering if that's what's kind of, sometimes there's a difference of opinion as to what type of CRS I'm thinking versus what you're thinking, and the management may be completely different.
Well, that's the ending of this thing, is that this is a multidisciplinary approach where you need the cardio-nephrologist to have the individualized treatment plan, and that's again why they want these clinical endpoints, so you can come to a consensus on which one you're trying to actually treat. The other thing that Dr. Julhar mentioned, and I want to say because I thought it was important in the paper as well, and this was studied in the European studies more, is that in type 1, there's a clear difference between transient worsening creatinine and acute kidney injury, both in the setting of diuretics and in the setting of ACE inhibitors. And so the current recommendation is not to hold ACE inhibitors and not to hold diuretics in worsening transient renal function. Obviously, you're going to go clinically based, but a lot of the times I see how people are reluctant in acute rising creatinine to either stop or not start an ACE inhibitor, or stop or not continue diuretics. And so far, the data that we have from the European studies, in which they used cystatin C and NGAL to see in the first 24, 48 hours if those patients were given creatinines and ACE inhibitors did better. And actually they did. Patients who did not receive the diuretics or did not receive the ACE inhibitors actually had increased mortality at 90 days.
So I definitely agree with Dr. Julhar and also Tushar. Tushar, you really did a good job on this presentation. So one thing is, when we are looking at heart failure, as Tushar just mentioned in the European trial where they're doing for the, especially cardiorenal syndrome type 1, when you're titrating the medications, I want to let you guys know is one thing you have to remember: if the patient has a naive heart failure, right, do not have a kidney problems, and then when you're titrating the medications, if the kidney failure is happening, that is okay, because we know that the patient does not have an underlying chronic kidney disease. So when patients are CKD 3 or 4, and then when they're having titrating the medications, that's where we have to see, is this is going to impact the heart failure too on the other side. And then more, as you see that most of the studies were done from CKD 3, not like 4 and 5, not much data is available. That's where most difficulty cases that I see is in 4 and 5, because most of the time the CKD 3 cases, they're actually managed more by the cardiology if it is a cardiorenal syndrome type 1. And then the up and downs can happen with the creatinine, potassium, and those things can be monitored and then changed accordingly. So even patients, when they come to the hospital with AKI, And then right away, I would not suggest to take off the lisinopril. Find out what is the reason for the AKI, and then in that case, if it is contributing, then I would take it off. But right away, there is no data to suggest that right away you have to take a lisinopril away when somebody who is already on lisinopril to stop it. But if there is a consistent, worsening of the kidney function, hyperkalemia, which is not controlled, in that case, yes, we have to discontinue that. And always remember, just giving lisinopril, just giving beta blocker is not enough, as our cardiologists very precisely emphasize on the maximum dose. The goal-directed therapy is very important, because if you don't maximize the dose, it is still not effective complete treatment for the heart failure. So I think that's where we do see a lot of AKIs when they are titrating the medications up. But it is okay to monitor them and keep following them more frequently than 3-4 months, where we can work with cardiology and nephrology together so that we can titrate. Because I usually don't change most of this medications unless I speak with the cardiology. Hey, you know what? This is what's happening. So let's maybe come down or go up or go down on the medication. So it's always better to talk with each other rather than patients get confused in between and we think they're taking some medication and actually patient doesn't take anything at all because of the confusion between the two doctors. So I think the communication is very important here, multidisciplinary approach, and we are able to do that right now. And one more thing is, when patients are heart failure, when we can diurese them because of the kidney failure is happening, they're CKD 4 or 5, the ultrafiltration, isolated ultrafiltration has been shown the benefit, and we are ready to do that. So that is something that we do. It is not like a dialysis, but it's kind of a procedure where we can isolate the ultrafiltration, we can be taken off for the symptomatic relief. Because for these patients, when we start diuresing them, the BUN goes up, creatinine goes up, they're already CKD4, they're going to 5, and they're getting more worse. In those cases, it is because of the cardiorenal syndrome, type 1 or type 2, they're getting worse. But I could not do much because the kidney is worse. So in those cases, I would definitely do isolated ultrafiltration that we have done for a patient before, but that is something we're going to work together with cardiologists to see further, because being our heart failure center, I think we should be more aggressive towards that.
Any other questions?
Thank you. That was great.
Great job, Tushar.
Tour de force.
I don't know. Where's the?
Great job.
They're not new. Patients is relatively new, but the ideas are. There was an idea on there that I don't recognize. There's such a thing as CKD-induced cardiomyopathy. I never heard of
Yeah,
that.
it's whatever. Yeah, well, the thing is, yes, type 1 and type 2 are heart failure, cognitive renal failure,